Hey everyone, and welcome to the next module of our course. So we're starting off by discussing sepsis and septic shock. Now this is a topic that we've all are probably well versed in, but we can take a deeper look into it and understanding how to recognize these patients, the concepts of or reasoning behind our treatments, and what to look for, especially as frontline care practitioners. So if you work in the emergency department, this is more targeted towards you, and you're probably well ahead of the game, but this will serve as our sepsis portion for our PowerPoint. I don't think it's really going to help to talk for an hour over a PowerPoint about sepsis. So hopefully this will be quicker and more to the point. So when we're talking about sepsis, we have to start talking about SIRS, all right? So our systemic inflammatory response syndrome. Now we know there's 4 criteria that we look at with SIRS, and to give us an idea of inflammation or potential signs of sepsis, right? So what do we have? We have our heart rate. All right, we have our temperature, we have our respiratory rate, then we also have our white blood cell count, or any signs of leukocytosis, or not. So with our heart rate, we're looking for a heart rate that's greater than 90 beats per minute. For our temp, we're looking for a temp of greater than 38 or less than 36 degrees Celsius. For our respiratory rate, we're looking for greater than 20. And for our white blood cell count, we're looking for marked leukocytosis, so greater than 12, or maybe situations like a neutropenic state, so the immunocompromised, or anything that demonstrates a massive use of our white blood cells. We can also incorporate bandemia, so the bands, so the immature neutrophils of greater than 10%, but that's neither here nor there. The most important part is greater than 12 or less than 4. All right, so we have these criteria, and what do they even mean? 90% of our patients that come in have at least 2 or 3 of these 4, right? Well, in SIRS, we're looking for 2, all right? So must have 2 out of 4. Again, if your heart rate's greater than 90 and your respiratory rate's greater than 20, you could have been working out. You could have just ran out some stairs or done something like that. But it's all in context. If we have a patient coming in, they look like they're sick, they're coming to the hospital for a reason, I'm sure it's not because they've exercised, unless they're complaining about chest pain. So we need to go from here. We've identified our patient. We have our 2 out of 4. We have, let's say, a marked heart rate, an increased temperature, or vice versa. But most of the time with these people, you're going to have more than 2 out of 4. So what do we do next? Well, we have to figure out what's going on with these patients, right? So we want to get some things done. And what are these things? We want to get cultures, right? So we're talking urine, blood, okay? We're not going to go to sputum or anything like that quite yet, but let's just get some urine and blood cultures. Quick stick, do whatever. And this is good to get before we start antibiotics. All right, that's not always possible, but it's always ideal to get it before antibiotics to isolate the pathogen. We can still get it after we initiate antibiotics, but it's not as useful. And also we have to understand the administration of steroids as well will affect this. What else do we want to get? We want to get a chest x-ray, right? See what's going on in there. Any overt signs of infection, pneumonia, or things like that. And then we're also going to want to get just a history, quick history. But the most important part of these cultures and chest x-ray. So what we want to eliminate right here, right? We want to figure out our pneumonias. We want to figure out if they're bacteremic. All right, or our UTIs. See, these are our primary or main culprits: pneumonia, bacteremia, UTI. If it's flu season, we also have to consider the flu. All right, but that's neither here nor there. So this is what we're looking for. It's pretty simple, right? We want to do this as fast as possible. We're going to be referring to what's called early goal-directed therapy. But you might be thinking, well, your resources are saying that's not necessarily the best bet. If you look at our resources, and this is in our discussion forum, the 3 trials that occurred after our early goal-directed therapy initial trial in 2001, they didn't say that it's worse, right? But they said it led to more expensive outcomes or more expensive care. But if you really read those studies, you'll understand that we're still using early goal-directed therapy. We're going through this this thought process when we're seeing these patients and systematically approaching things and knowing that we have to give antibiotics sooner, knowing that we have to isolate the pathogen, right? So at the end of the day, it's all early goal record therapy, despite what people say about that, the River study or not. But that's where we learned all this from. We're going from there. All right. And one more note. If someone is not bacteremic, that doesn't mean that they're not septic, okay? Let's just clear that up as well. So sometimes people associate bacteremia with sepsis. That is not necessarily the case, so we have to just put that out there as well. All right, so now we figured out our patient is septic, right? Well, how do we define that? What's the difference between sepsis and SIRS? So for our purposes here, we're going to keep it pretty simple, right? So let me just draw a line here. All right, so let's say we have SIRS and a source. And a source meaning source of infection. Now we have sepsis. Okay? And this source could be microbial, or it could also be trauma. All right? Or anything that will increase our inflammatory response. All right, so our innate immune system's getting a little overactive. So we have SIRS and a source, now we have sepsis. So what do we do with these patients? Do we bring them to the unit immediately? Do we put them on the floor? What do we do? Well, let's think about that as well. So let's say we have severe. So what do we mean by this? And then also we have septic shock. Okay, where do we draw the line here? Well, right there. So severe sepsis, how are we going to define that? Now we have SIRS and a source where we have a septic patient. Are they severe? Are they in septic shock? What do we do? So our severe septic patients we can keep on the floor. But the main thing that we want to know about our severely septic patients are that they're fluid responsive. Meaning that you give them a bolus of fluid and their blood pressure improves, right? So you give them fluid, maintenance therapy, antibiotics, and monitor. Severe sepsis, I should define this earlier. For this lecture, we're going to call it sepsis. So we have our SIRS criteria over there plus our source, so sepsis, plus one organ dysfunction. All right, and that's a simple way of saying low blood pressure, okay? Because that's what we're going to see first. We'll see the kidneys and everything thereafter. If we're seeing the kidneys now and all those renal injuries or signs of acute renal failure, we're probably more in septic shock, right? So we just want to see the response to fluid. So what do we do? Fluid, antibiotics, and maintenance therapy. Okay, simple enough. So we keep them on the floor, we take care of them, we send them out. These are the people that will go home. All right, so let's say they came on a little bit later. They neglected to go to the ED or whatever it may be, or they just have a really nasty bug. Well, we're going to call these people in septic shock if they are not fluid responsive. So meaning that we've given them a little bit of fluid, or we've given them fluid and it's not doing anything, so little improvement. So what are we going to need here? We're going to need vasoactive drugs. And this means they're going to be in the ICU, right? They also have evidence of ischemia and maybe a lactic acidosis. And that means that our mitochondria are not utilizing our oxygen very well. O2 dysfunction. So generally, we're going to see a multi-organ failure state. These people are going to go to the ICU, and hopefully we can help them out. But they might need some more interventions, so they might need an ART line for that blood pressure, right? They're going to be on vasoactive drugs. It's probably a good idea. Put an ART line in. We also might put a central line in, right, for CVPs. MAP. All right, these are things we really want to look at here. So why are we putting in these ART lines, looking at central lines and things like that? Well, we're not putting a central line in just to give vasoactive drugs, but we can also measure our CVP. I should have said vasoactive drugs. Okay, because you don't want to put vasoactive drugs through a PIV. That's a horrible idea. You're just asking for tissue necrosis. But if you have to, you have to, but hopefully it's for a short amount of time. All right, so beyond this, when we're in our septic shock, we have to worry about our multi-organ dysfunction or multi-organ dysfunction syndrome, and that's the progression of septic shock, okay? So we're gonna go from there to here. So this is sepsis, and the patient is sick as snot, all right? Or you can add whatever S you want there. We're gonna keep it PC for this course. Sick as ... All right, so these are our ARDS patients. Shock livers, renal failure. So the ones we usually see in the ICU, and these people might not make it out of the ICU. They're pretty sick. So let's go back to that early goal-directed therapy, right? So now we have a central line in, we have an ART line in, we've given these people a little bit of fluid, they're not really doing anything, and we need to start them on vasopressors. But what parameters are we looking at? And again, we're gonna get back to this early goal-directed therapy. All right, and the parameters we want to titrate our drugs to or monitor are our CVP, right? 10 to 12. We're going to get into that later in its utility. Our SCVO2, we want to keep that greater than 70%. Go to look at our MAPS. Of course, we want to keep our MAPS greater than 65. And then our urine output. It's kind of nice because we have 4 criteria for our SIRS, and then we have 4 criteria for our early goal-directed therapy parameters. So urine output, want to maintain a urine output of 0.5, so 0.5 cc's per kilogram per minute. Or sorry, per hour. That's a lot per minute, per hour. Kg per hour. Okay. Now just remember our normal urine output for an adult is about 800 to a liter. 800 mLs to 1 liter per hour. Okay, so if you do the math there with a 70 kilogram patient, you'll get the numbers there. So it's really not all that much. Okay, so how do we do all these things? What's the point of doing this, and why do we pick these numbers? Well, first of all, a lot of studies, a lot of human studies, a lot of randomized control trials that we came up with these values that were like, okay, this is the minimum we need for these patients to survive. This is what we need to target to. 1, make sure we have preload, right? So fluid resuscitation goals. 2, make sure we are providing oxygen. So providing enough metabolic support. 3, we're perfusing our organs and our kidneys. All right, because our kidneys are going to filter everything out. We have a lot of stuff going on there. All right, so that's where all these things are coming from. All right, so how do we treat this? How do we maintain those early goal-directed therapies? Well, I drew some images here. I guess you can call them that, of vessels, right? So what's happening in septic shock, in this multi-organ dysfunction, these very sick patients? Well, for one, we have our vasodilation, right? And what does vasodilation mean? That means a decrease. Let's put it up here. This means a decrease in our SVR, systemic vascular resistance, and peripheral vascular resistance, right? So this is where we get our widening pulse pressure. All right, P and SVR, okay? And we get that hyperdynamic LV. Okay, so that means our left ventricle is not getting enough preload back to it. It's squeezing as hard as it can to maintain that cardiac output because we are in a high flow state here, all right? What's over here? So here we have a really bad version of a leaky capillary, all right? So we have volume needs, decrease volume, so decrease preload. All right, so we don't have enough stuff going back to the heart, therefore we can't pump anything out. And over here, we have some poor contractility. All right, so our heart's not working. So these are 3 of the mechanisms that you'll see with hypoperfusion, things that will affect our early goal-directed therapy parameters that we'll see most of the time in a septic patient. Mainly these first two right here, okay? We're gonna get to poor contractility in a second, but what do we wanna do? We wanna maintain, let's reiterate this, we wanna maintain our MAP. Let's put it right here. We wanna maintain our MAP, right? Greater than 65. And that's our perfusion. We wanna maintain our CVP between 10 and 12, which that'll change in a second just to confuse everyone. And then we also want to maintain our SCVO2 at greater than 70%, okay? I'm gonna leave the urine output out of this because it's implied that if we're perfusing our kidneys well enough without any sort of pre-renal issues that we should have decent urine output, okay? So what are we looking at here? We're going to be looking at this equation that really ties in everything that we're looking at here. So our MAP equals cardiac output times systemic vascular resistance, right? Cardiac output, what is cardiac output? That is heart rate times stroke volume. And what is stroke volume? Stroke volume is preload and contractility. All right. So we need to adjust all of these things to make sure our MAP is adequate. And we have almost everything covered here. Here's our preload, our contractility is up here, or more or less our cardiac output, and then our systemic vascular resistance is over here. All right, so what do we do in these situations with each one of these deficits? So what we're gonna wanna do with all of our patients first is give fluid. Give tons of fluid, okay? And by giving fluid, we're talking on the order of liters. So you can go about this by giving 30 cc's per kg at first, but generally you're going to do 500 cc's to 1 liter over the course of 30 minutes. Okay? And you're going to keep doing that until your blood pressure gets better, honestly. If it's not, you're going to start vasopressors. And vasopressors go in a certain order, as we've learned. So we're going to start off with levo. We're going to go into vaso, and then we're going to start with epi at the end. Okay, and if you're going beyond that, there might be some family discussion needs or anything like that. With epi, you can also give some steroids. Because in these patients, their adrenal glands might be absolutely exhausted, and therefore we're never going to get a good sympathetic response, right? Our steroids would help augment that response, and we'll end up having some ADH secretion or anything else that's going to go on with our mineralocorticoid and glucocorticoid deficit. So here we're going to write vasopressors. Here we're going to write vasopressors. Here's where our fluid is going to come into play, right? So give a bunch of fluid. All right, since we established the basics of treating the septic shock, so we've already given these people antibiotics, we've gotten blood cultures, we're trying to figure out what's going on with them. They're a multi-organ failure. We want to give them fluid and vasopressors to maintain these criteria, right? But what's going on in the immunological sense? So we're going to keep it simple here. We have an overwhelming immune response. And in this immune response, we're dealing with a lot of cytokine release, cellular damage. So we have these things called PAMPs, pathogen-associated molecular patterns, and damage-associated molecular patterns, right? And these things are recognized through pathogens, right? So let's say gram-negative, right? So that'll be our lipopolysaccharides, or that'll be our endotoxin, all right? And that's our main culprit in our septic shock generally. Our damage-associated molecular patterns are from our tissue injury, all right? And so our cells see these things, these molecular patterns, and they respond to them by releasing cytokines. All right, and this is a very simple way to say it. And the cytokines we're really concerned about, all of them actually, but IL-1 beta is a primary antagonist in this situation. What that'll do is cause vasodilation. This is secreted by neutrophils, macrophages, dendritic cells. So vasodilation. We're also going to have hyperthermia. So it's a pyrogen to help fight this infection. So that'll be with our hypothalamus. Remember that. We're also going to have neutrophil adhesion and communication. So that's what it'll do. So it'll help the neutrophils stick. Okay? So that's the point of IL-1 beta. People make cytokines sound like they're a very bad thing and all they want to do is destroy us, but there is a point to them. We just have an overexpression. And these are secreted from our immune cells, right? So we'll just leave it at that. In our innate immune system, we also have IL-6. We have IL-8, and that's going to attract neutrophils. It's also called CXC8. And we're going to have IL-12. And so on and so forth, right? So we have an overexpression of these cytokines based on our immune response. These can all contribute to things like DIC, hypercoagulability, and a bunch of other issues that are associated that'll further propagate our multi-organ dysfunction. But there's not much we can do about that other than to ride this out and make sure we maintain our life-sustaining goals, okay? We keep talking about fluid, right? Fluid. So how do we assess this fluid? So you want to say CVP, right? So we want to keep our CVP in between this very tight range. But the thing about CVP is that it's not really a good indicator for our fluid status. I mean, I hate to say it because we always refer to it as that, but it's an easy way to refer to our fluid status. You just lay the patient flat, get a measurement. Okay, they are less than 10. Let's give them more fluid. They're more than 12. We're probably over-resuscitated, but it's not that easy. So here are two other ways to assess your fluid status. They're pretty simple. One you can do is called the leg lift, which I don't see people do very often, but it works. And so if you have your leg lift, so if you lift the patient's legs higher than their head, right? So you have gravity, give them a bolus of fluid basically back from their lower body, and you have a greater than 10 millimeter of mercury increase in their MAP, that means they're fluid responsive, which means that give more fluid. Okay? And you're going to assess this after you keep bolusing these people. If maybe you're having to go up in your vasopressors, but there's one novel way to kind of look at your fluid responsiveness. So fluid responsive means that the patient needs more fluid. You give them fluid and something actually changes. The second way is to do ultrasound. All right. And I'm sure you guys have seen your intensivists do this. Basically, you're going to put an ultrasound by their IVC. So around their diaphragm area, down their belly. And you're going to see a few different things. So you can see a hyperdynamic IVC, meaning that it collapses. We'll just do a dotted line here on every heartbeat, right? So if it collapses on every heartbeat, the heart's sucking all that volume in and it's sucking down. Again, I like to make analogies to ECMO. If you have a lot of circuit chatter or suck, you have the same idea here going on. You'd probably need more volume to sustain this. So it's the same idea. So we're going to be sucking down an IVC, and we'll see that in ultrasound. It'll look just like this. I mean, not just like this, but it'll look very similar, and then you're going to need to give more fluid. Okay, so increase fluid or volume. Okay, if you have a fixed and dilated IVC, I think you know where I'm going with this. You're maxed out. Okay, and we're gonna hold the course. All right. So it'd be nice if you're bedside and you want to assess someone's fluid status and you don't really know what's going on with them, you're going by CVPs, they don't seem to be getting better. Might be good to say to your intensivist, hey, let's break out the ultrasound, let's look at their IVC. It might give you some kudo points, but it actually might help the patient more than anything. One thing we didn't talk about before I finish up here is our SCVO2. So SCVO2. One would think this is generally a cardiac parameter, and we're going to use it as such in sepsis, but also that our SCVO2 is going to give us an idea of our O2ER, right? Our oxygen extraction ratio, which is what, normally 25 to 30% around there. All right. So we're going to have the difference between our SaO2 and our SVO2. All right. So let's say this is 100. And let's say this is 75. So then we have what, an O2ER of 25. All right, so that's normal. In sepsis, what we're having here is one big shunt. We're having one big AVM and the blood's going around super fast, right? Super fast. And we're not giving our blood enough time to take out oxygen. So let's just show what it might look like here as a donut. All right, so our we're extremely vasodilated. Blood's going so quickly throughout the system. We have a high cardiac output state, right, with a little peripheral vascular resistance or systemic vascular resistance, so we'll have this wide pulse pressure. All right, So what's happening here, if we have cells down here, they don't have enough time to get oxygen, right? So you might get one there, you might get one there. Let's make this a different color. So let's say we have our SvO2 coming back at like 85%, and it's going out at, probably not, but 100%, right? This is where we want to watch our SvO2, but there's not much we could do about it, right? As far as our early goal-directed therapy goals, right? So what are we going to do? If we increase their peripheral vascular resistance or systemic vascular resistance, we might have a slowdown of this flow. We'll increase their blood pressure, improve perfusion, and we might even out a little bit, right? But where the SvO2 can come in is that if we've been dealing with these patients for 2 days or more, they're on vasopressors, there are 2 vasopressors, we keep giving them fluid, they're not getting any better. What else provides oxygen to your tissues, and what else could be affected by severe acidosis and all these other infections? Your heart, right? So we have to consider cardiogenic aspects of septic shock. So we'll have a heart here again, and we'll draw our system here. So if we had a little element of cardiogenic shock or limited cardiac output, we're going to have the same dilation, but this is going to be sluggish, right? Because our heart's not pumping the blood, so it's just not as fast. So it's not as fast and it's dilated. So that's pretty deadly. So what we have here are our cells that are being perfused, and we're having a ton of oxygen being taken out, all right? And with that being said, we can have an O2ER of about 50%, but we're getting our SvO2 of 50%. So therefore, we have to understand our cardiac output is not sufficient to maintain the situation. So what do we do here? Well, we can give some dobutamine or inotropes. All right. And we can also assess this via echo. All right. But this is a very distinct possibility in pending heart failure and cardiogenic shock within septic shock, and we have to be aware of this. But we have to understand that this is due to slow flow. This is from fast flow. Okay? Slow and fast. One thing to note about this is resuscitation methods. So we've talked a lot about fluid, but what about blood? What about colloids and things like that? So let's say we're in this area with our SvO2 is, or O2ER is very high, or SvO2 is very low. So if our SvO2 is low, that can mean a lot of things as well. That can mean you have a low hemoglobin, right? Or it could, and that would make sense in this situation. Let's say you are having some sort of DIC and you're bleeding or having hemolysis or something like that, or low hematocrit. So let's look at this again over here in the sense of our circulation. And let's make things a little more simple. So we have a circle for circulation, right? Let's say that our O2ER is again like about 50%. So we're having, or let's say it's 40, right? 40% here and then 100% here. All right, so our normal SCVO2 is 75%. So let's say you had, just theoretically, you had 8 hemoglobin, right? And each hemoglobin carries 1 molecule of oxygen. This isn't correct, but this is what we're going to use. So you have 8 hemoglobin, and each hemoglobin carries 1 oxygen. So you come back, you get rid of 2, now you have 6 out of 8, and that equals 75%, right? So what happens if your hemoglobin drops? So say you have 4 hemoglobin. 4 to 4, you lose 2, now you have 50%. So your O2ER increases that much. So that's, of course, we already know the importance of hemoglobin in states of oxygen delivery. So what we have to consider here is another transfusion or another parameter to look at, and that's our hemoglobin. All right, and we want our hemoglobin to be greater than 8 grams per deciliter. All right, less than 8 equals transfuse. Okay. Some units, if you work in a cardiothoracic unit, are going to have a much lower threshold. And that lower threshold is because they don't want to develop any sort of HLA antibodies or any sort of transfusion reactions or graft versus host disease. So you have to keep that in mind as well. Their thresholds are much lower, and that might be very frustrating to you. But one more thing before we leave. Fluid. I kept saying that over and over again. What do I mean? So you have normal saline, then you have lactated ringers. I always vote for lactated ringers, okay? If you give massive transfusions or infusions, not transfusions, of lactated ringers, which they do in the OR constantly, you have about 4 milliequivalents of LR in each bag. Let's say you gave 10 liters of resuscitation, like they would in the OR, you're only giving 40 milliequivalents of K, right? So people are always worried about the potassium content in lactated ringers. This is not going to affect your patient, okay? It might be a very mild effect, but this is actually what we give people with asymptomatic hypokalemia. That's the dosage you get. Normal saline, you have a risk of hyperchloremic acidosis. So CL for acidosis. This combined with a lactic acidosis is bad news. If you're going to be infusing about 10 liters of this stuff, right? So a lot. So I always suggest going for lactated ringers. In any situation, I always suggest lactated ringers for this specific cause. It's very benign. The effects are overstated, and I think that as far as crystalloid substances go or infusions, we should always be giving lactated ringers. There's a time and a place, but you can always make that argument of the potassium in LR, but it doesn't really matter at the end of the day unless they have, their kidneys don't work at all. But in that case, they're on dialysis. So we can probably mitigate that. All right. So a little bit of information about sepsis, septic shock, and how to treat. Hopefully this aligns with the PowerPoint well. Let me know if you guys have any questions. Thanks.